So this video is going to go through some of the main models, the health belief models that have been used widely by health behavioural researchers to understand why people make the decisions that they make in relation to their health. So the first one is the health belief model, and that was developed around the 1950s by a group of social psychologists. They work in the field of public health, and their key concerns really were to understand why some people don't use health services like immunisation and screening despite the promoted benefits. The model itself is still in common use. There were previously 4 main constructs, but those have increased as more people have come to understand the health belief model and adapt it. So the first construct is perceived susceptibility, or it could be termed as perceived vulnerability. And that's the individual's perceived risk of contracting the disease if they were to continue doing whatever it is they're doing. So if they weren't to change their action, how likely, how susceptible are they to contract the disease? The next construct is perceived severity. So it's again how severe or how serious the consequences are perceived by the individual if they were to contract the disease, if they again don't change their behaviour. Then we've got the perceived benefits, and they refer to the perceived advantages if the patient or the person was to take an alternative course of action, so change their behaviour. And it's basically their perception as to how much the risk of the disease or the severity of its consequences would actually decrease. The next one is perceived barriers, or it could otherwise be termed as perceived costs, and that refers to the patient's perceived disadvantages of adopting a recommended action, as well as really thinking about what kind of obstacles that might prevent or stop them from getting successful performance. Then we have the self-efficacy. So that really is about whether a patient or person feels they have the ability, the willpower, the motivation to actively change their behaviour. So that will play a part. And then we've got something termed cues to action. So cues to action are basically triggers that can prompt a health promoting behaviour or a change in a behaviour that's otherwise risky. Now, these could be internal or external. So something internal could be something like pain, if a patient starts to get pain or symptoms, and they would be internalised. External cues could be something that's happening outside, like an event or information from others or the media or healthcare providers. So something's happening outside of that person. And then lastly, we have this factor known as the modifying variables, and those are the individual characteristics of the person, and they can include their demographics, any kind of psychosocial and structural variables. They can affect a person's perceptions. They can affect how serious or how vulnerable that they are to contracting the disease or getting the disease, and it can therefore impact their health-related decisions and behaviours. So that those kind of factors could include age, race, sex, levels of education potentially, and psychosocial variables could include personality types, social class, peer pressure. And really the health belief model suggests that modifying variables can affect health-related behaviours indirectly because they affect the perceived seriousness, susceptibility, benefits and barriers. So really it has an impact on the constructs that I've just mentioned. So it is thought that the interrelationship of these constructs will actually predict the likelihood of whether a person will actually engage in a health promoting behaviour. So would they actually change their current risky behaviour towards something that is healthier? The next main theory is the theory of planned behaviour, And that really started as a theory of recent action, and that came about in the 1980s. And primarily that was there or came about to predict an individual's intention to engage in a behaviour at a specific time and place. So really it's to understand why people do things that they do. So it was intended to explain all behaviours that people have control over. So the key component of the model is actually behavioural intent. It's all about the intention. And it was recognised that behavioural intentions are influenced by the attitudes about the likelihood that the behaviour will have an expected outcome. So the anticipated, the individual will almost critique whether they will actually have the unexpected outcome. There will be also a weigh up of the risks and benefits of that outcome, and those will interplay as to inform whether the individual actually change their behaviour. So this model has been used successfully to predict and explain quite a wide range of health behaviours and intentions. So you'll see this in literature quite a lot, and mentioned when people are kind of designing public health campaigns and such like. And things like stopping smoking, reducing drinking, how to use health services, improving breastfeeding amongst mothers, maybe reducing substance use. Those kinds of things will use this model in promoting services, in trying to change behaviours. So it's quite interesting to actually map out how those kind of services and campaigns have actually been designed. So the theory of planned behaviour states that behavioural achievement really depends on motivation, so the intention, and an individual's ability, so their actual behavioural control. And it really distinguishes between three types of beliefs: the behavioural, the normative, and the control. So the model is comprised of 6 constructs, and they represent a person's actual control over the behaviour. So the first construct is all about attitudes. So this refers to the degree to which the individual has a favourable or unfavourable evaluation of the behaviour of interest. So how do they feel? What's their attitude towards this behaviour? And that will entail consideration of the outcomes of performing the behaviour. So how does it make them feel? How does it make them feel, think or perceived? And that will impact their attitude. The next construct is the behavioural intention. So that refers to motivational factors that influence the behaviour. So if there's a stronger intention to perform the behaviour, then they're more likely to behave in that way. Then the next construct we have is subjective norms, and that refers to the belief whether most people approve or disapprove of the behaviour. So that's about kind of the social acceptability or maybe peer pressure. And that really relates to a person's belief as to whether peers and people of importance to that individual think they should really engage in that behaviour. So that's termed subjective norms. Then we've got the social norms, and that really refers to customary codes of behaviour in a group of people or larger cultural context. So if we consider someone living in a village as opposed to someone living in a city, maybe nowadays the difference in thinking, maybe, there might be very little difference in thinking. But if we were to think maybe about 20, 30 years ago, there may have been a difference in behaviour based on where that person lived. So social norms are considered normative or standard in a group of people, and that will impact whether an individual has an intention to change their behaviour. Then we've got this construct called perceived power, and that refers to the perceived presence of factors that can really facilitate or prevent performance of a behaviour. So that can contribute to the person's perceived control over those factors. So the kind of barriers and facilitators as to whether that person can actually make a change. And then the last one is the perceived behavioural control, and that refers to the person's perception of how easy it would be to perform that behaviour. Now, perceived behavioural control really varies across situations and across actions, and that results in individuals having various perceptions of behavioural control depending on the situation. So maybe in one context where they're in a group of people where it's very acceptable to behave in a certain way, then the perceived behavioural control is high. They will have good control over that intention to undertake that behaviour. Whereas if they're in a different kind of social group where the behaviour isn't quite accepted, or it's taboo potentially, then the individual may feel they have less control to make that change or undertake that behaviour. Now, that particular construct was added later, and that really shifted the original theory of resistant action to the theory of planned behaviour, and it is what it is today. So these are just two of the health belief models, and these are the two really that are used in modern day to inform public health campaigns and to design services, and also to evaluate services, and used for various other things in marketing. It can be used in different fields, really. Now, both models do have their limitations. I won't be going into them now, so that forms some of the discussion as we look at the seminar material. And I think as you kind of engage and observe more of healthcare services and how patients look after themselves and make decisions about their health, you may be able to understand a little bit more about why people make the decisions that they make. So aside from the belief models, we also have stage models, and they use similar concepts, but they organise them in a different way. So according to this approach, behaviour change really involves movement through a sequence of kind of distinct stages, and different factors are assumed to be important at different stages. So people in different stages are assumed to require different types of interventions to encourage them or help them to move from one stage to the next in the sequence. So the dominant stage model of health behaviour is known as the trans-theoretical model, and that really developed from studies of processes of change in psychotherapy and smoking cessation. So smoking cessation really was the topic that allowed the trans-theoretical model to develop. Smoking still accounts for the majority of applications of this model, but it has now been applied to quite a wide range of health behaviours, including things like condom use, uptake of exercise, whether someone uses sunscreen use, and healthy eating. It's often referred to as the stage of change model. The version of this model that's most widely used in recent years specifies 5 stages. So we've got the first one, which is pre-contemplation, where an individual doesn't really recognise a need or an interest for changing their behaviour. Then we've got contemplation, where the individual starts to think about change, starts to consider it, that they may, want to make a change to their behaviours. Then we've got stage 3, where they're actually preparing or planning for a change. Maybe they're buying the right resources or reading around making a change, or getting rid of the taboo substance like cigarettes or something like that. And then they move on into action, and that's where they adopt new habits. They start actually making the actively new behaviour. And then they move into stage 5, where it's an ongoing practice. It's a maintenance of the new and healthier behaviour. Now, I've said that, I've kind of phrased that, presented that in a linear, stepwise process. But if you can imagine, it's not always linear. Individuals can find themselves going backwards and forwards between stages. They may think about changing, they may prepare, but then they may go back to thinking about it and actually not go through to action. So it isn't a linear process, really. Individuals can move between the stages, And even they can go a full circle, so they can go from maintenance and actually move back into the poor behaviour again. So the model is limited to describe the complex nature of how people make decisions, but it does offer the ability to kind of provide a lens to understand why, again, patients or individuals may make the health decisions that they make. Of course, it's not only important to understand why people make the decisions they make in relation to their health, but if we can understand why they make the decisions, we can be more informed to plan interventions, to plan services, to frame our counselling, to tackle those different constructs potentially towards achieving a healthier decision to impact the patient's way of thinking, their behaviour, their intention towards making healthier choices. So that's why it's important for healthcare professionals to have an appreciation of behavioural science, because that's what it is. So you can understand your audience. If you can understand your audience better, if you can understand your patients, your clients better, then you're able to tailor the services that you provide to make them more accessible. And therefore, hopefully, patients will have better uptake and therefore make healthier choices.